Great. Good morning, good afternoon, everyone. As Sujina just said, today we're going to talk about one of the most important principles of collaborative care, measurement-based care, and how to accomplish that with a registry. So I am Diane Powers. I'm co-director of the AIMS Center at the University of Washington. I'm joined today by Shanda Wells from the University of Wisconsin, who's going to talk about how they built a registry into their EPIC EHR, and she'll also be joined by her colleague Tristan. And then we're also joined today by Susie Hunter, who's the technical project manager for the AIMS Center, and she's going to talk about the collaborative care registry that we offer. So by the end of this session, you should be able to define measurement-based care for behavioral health, describe registry options for tracking a caseload of patients, and list the important features of a registry for measurement-based care and caseload tracking. So first, let's start with the 5 key principles of collaborative care, because these really serve as the foundation for our conversation today. Collaborative care starts with a patient-centered team comprised of the patient, a primary care provider, a behavioral health care manager, and a psychiatric consultant. This group works together using these other principles to provide care to patients with a diagnosable mental health condition in the primary care or general medical setting. Collaborative care is population-based, so care is provided to an entire defined population of patients in a medical setting. This is one of the ways in which a registry is key. It really helps you keep track of that entire population and to organize and drive the care that's delivered. At the heart of collaborative care is measurement-based treatment to target. So mental health symptoms are measured at baseline or at the start of care, and then repeatedly throughout treatment to be able to monitor, and measure progress toward clinical goals of symptom response and remission. This is also where a registry is a key component of collaborative care. The ability to track patient outcomes and to know where you are is a key component. So, tracking that trajectory of scores over time for each patient and at the population level as well is critically important to satisfy this principle. The treatments that are used should be evidence-based and appropriate for the primary care setting, meaning that they're brief, structured, and focused on symptom reduction. And then finally, collaborative care is accountable to patients, other members of the care team, and also to payers. So in 2015, faculty from the AIMS Center partnered with other national leaders to develop this report for the Kennedy Forum. One of the conclusions of the report is that for measurement-based care to be effective, there's good evidence that symptom severity must be assessed frequently and shortly before or during the clinical encounter. Yet only 18% of psychiatrists and 11% of psychologists in the US routinely administer symptom rating scales to monitor treatment response. So this can be a pretty big change for folks in the behavioral health space. In collaborative care, clinical teams use measurement-based care to push patients through treatment more proactively. Instead of allowing patients to stay on a treatment plan that isn't working, a good collaborative care registry will quickly and easily identify patients who are not getting better so that the treatment team can make a change. If a patient hasn't had a 50% or greater reduction in symptoms within 8 to 10 weeks on a particular treatment plan, something should change. So what that something is depends on where you started and what's happening with the symptoms that the patient has, but something should change. And that clock should reset each time a change is made so that you're not letting patients languish on either an ineffective or a partially effective treatment plan longer than they should. And when you do that, you can see that patients achieved remission of symptoms in only 86 days as compared with the usual primary care approach, which took patients 614 days to achieve remission. So really driving this measurement-based treatment to target approach and doing that well really makes a huge difference in how fast patients get better. Across many years and many programs, the average length of a collaborative care episode of care is about 6 months. Many patients will get better sooner than that, and some patients will need longer. So the length of treatment should really be driven by patient clinical outcomes rather than a specific predetermined time frame. It's also important to keep in mind that 50 to 70% of patients need at least one change in treatment to achieve response. So research shows that every time you make a treatment change, you get about 20% of the remaining patients better. So the key here is just don't give up too soon and use your registry to help you keep track of who needs your attention. Measurement-based care requires frequent measurement. It's like putting a blood pressure cuff on a patient being treated for hypertension. How can you know where you are in relation to the clinical goal without measurement of where you are in relation to that goal? So the same is true for mental health conditions. If patients understand the rationale for repeating symptom monitoring measures, they're usually pretty happy to go along with repeated measurement. It's important to help them understand this rationale and enlist their support in the process. So a good registry helps you quickly and easily see the original symptom score as well as the most recent score so that you can compare them. Is the patient at least 50% better on the PHQ-9, or have they had a 5-point decrease in the GAD-7 if those are the conditions that you're treating? If not, when was the last time you discussed the patient with the psychiatric consultant and made a treatment change? So every appointment and case review is a decision point. So as I just mentioned, it's important to enlist the patient as a member of the treatment team. It's important for them to share responsibility for tracking their symptoms over time, which symptoms are improving and which are not. So research shows that patients who are engaged as allies in this particular way are more knowledgeable about their condition. They're more attuned to their symptoms and the situations that may affect their symptoms. They're better able to partner with their providers in treatment. They're better able to recognize when they're improving. They're more aware of warning signs that they may be relapsing once they're better, and they're better able to set self-management goals. So collaborative care requires a registry, and as I mentioned, this supports the principle of population-based care. You're tracking and treating an entire population of patients. It would be pretty tough to do that without anyone falling through the cracks without using a strong registry. Registries that support collaborative care must be able to do the following. So they must be able to track clinical outcomes and progress at the patient, individual patient, and caseload levels. You need it to be able to track clinical outcomes for the target population, to prompt treatment to target by summarizing patients' improvement and challenges in an easily understandable way, such as charts, and then facilitate efficient psychiatric case review. So that allows providers to prioritize patients who need to be evaluated for changes in treatment or those who are new to the caseload. To use the collaborative care billing codes, you must have a registry. The codes are now covered by 24 state Medicaid plans and most commercial insurance plans, in addition to Medicare. So there are different registry options, and they each have their pros and cons. What we're going to do today is we're going to hear about two different options. The first is building a registry into your EHR, and Shanda Wells and Tristan from University of Wisconsin Health are going to talk about the registry they built into their Epic Health Record. And then second, we're going to take a look at a registry that's offered by the Ames Center. But before I move on to those to having folks talk about the registry options, I just want to stop for a minute and see if there are any questions about measurement-based treatment to target as one of the key principles of collaborative care. Okay, well, I'm not seeing anything in the chat and I'm not hearing anyone. So let's go ahead and move on and take it away, Shanda.
Thank you for that. Yes, my illustrious colleague Tristan Lashesky will be joining me, and as he's the one who did a lot of the build for this particular registry, as you'll see. So Tristan will be piping up here in a moment. Next slide. So I'm just going to talk really briefly about UW Health, give you some terms because we call things a little slightly different wording because of our Epic system that we use. And then I'll talk to you kind of about how we use our system, the workflows and the tools that are embedded in it. So in case anyone out there doesn't know, UW Health, which is the University of Wisconsin, not the other UW, we are in Madison, Wisconsin. We are a large academic medical center that covers both South Central Wisconsin and Northern Illinois. Next slide. We have about this is a little bit of an outdated slide, but this is all that we encompass. We have close to 353 member health plan that we support. So we're seeing hundreds of thousands of patients every year at our health system. Next slide. So the registry that we use on our Epic system is actually called a reporting workbench. So you're going to hear it called a reporting workbench. It is the registry. They're the one and the same. There's just a slightly different wording. We use a tool in our Epic system, our EHR, called an episode of care to help track patients through every episode of their collaborative care. And then you'll see some population for behavioral health collaborative care, which is that the patients with an active episode for collaborative care. So they're currently being seen. All right.
All right. Can everybody hear me?
Yeah.
Excellent. And good morning. So just want to talk about the process that we use for collaborative care. Just in general, it all starts with the PCP identifying the patient. They put in order for a consult in our Epic system, and then the BHC performs a warm handoff. That's when we create an episode of care, which is something in the EHR that indicates the patient is enrolled in collaborative care. An assessment is performed, and then there's collaboration between the entire team. And the reporting workbench that Shanda mentioned uses that list of patients or registry that are enrolled in collaborative care to show information about them. And so obviously we have visits with our patients, we perform outreach, and when their symptoms are reduced enough, we will hopefully discharge the patient and we resolve the episode. That's the mechanism that removes them from the reporting workbench report and the registry as well. Next slide.
Yeah, so how does someone functionally get added to our reporting workbench? What happens is that when we get the warm handoff, the BHC, which is what we call our care managers, they would open up an episode in our EHR and add themselves to that patient's care team. And that automatically, when they run then their reporting workbench, that automatically pulls all those patients into that registry. So it's kind of behind the scenes done through our EHR. Then the discrete data that we can see in our reporting workbench, which we'll show you in a little while, we'll show you what some of that looks like. That is brought in through a navigator, which is basically the screen that we document on in our EHR. And it has smart forms that can populate that reporting workbench. We'll show you some examples of these in just a minute. Next slide.
All right, speaking of tools, we have the episode of care, which indicates enrollment. And then smart forms, which are just fancy things you can put data in that's discrete, that can be shown elsewhere and used for reporting. Then we have a reporting workbench that uses that registry for people that have an episode. Another really important thing that we use is time tracking, which is another smart form. The clinician can put in the time spent with the patient and time spent in chart review, which all totals up to what we could charge based on time in the CoCM model. And then we also have a team psychiatrist review that can be used to indicate that we need to have a review with a team psychiatrist to perhaps recommend medications, interventions, and other things to improve care for the patient. Next slide, please.
I want to jump in really quickly here, Tristan, just to make it clear to everybody that we are using collaborative care billing. So you'll see some allusion to that in these slides. Yeah.
And it's not just an illusion, it's real. All right. So speaking of tools, and we did get permission to show some screenshots, so hopefully that's helpful to visualize what we're doing. But this is what we call a navigator, or a list of things that behavioral health clinicians use in the system. And at the top, we create our episode there, we name it, and then we also have our time tracking. And if you look at that list down the left, there's a lot there. There's a lot of interventions. There's a lot of screenings that we can do. You see the PHQ and GAD7 and other good things that we're using as part of that. And so in the next slide, we're going to look at what the episode smart form looks like. So we'll go to the next slide. And so when we create an episode of care, we fill out this smart form that's stored in the episode, and we fill in who is working with the patient. And when they're active, they click that button, which segment they're enrolled, and so on. And then we have the reason in there as well. So we can see the primary reason for why we've enrolled that patient in primary care. And so if we go to the next slide, this is how we divide labor amongst our BHCs. I believe there's about 40. Shanda, correct me if I'm wrong.
45 now. Yep.
45. Wow, we grew since the last time. So this is one of the ways that we kind of divide labor. So each BHC sort of adds themselves to the care team. And this is helpful because not only does it help reporting workbench give them just their patients and not all the patients, but it helps everybody in the care continuum see what care is being provided to that patient and who they can talk to about it. And we'll go to the next slide. And so we'll do the first click here. Our reporting workbench has too many columns to show in just one screenshot. So this is a little animation if you want to left click in there. So this is the first bolus of columns, and we can see I've blotted out the patient name and other PHI, but essentially we have the patient name, we have how much time we spent with them this month, the last time they were billed. And a lot of columns in here. We use a lot of outreach in Epic. So we have that team psych review, and the next time we want to have a team psych review is shown there. We also see if they're on medications for opioid use disorder. We have the last behavioral health outreach, the next behavioral health outreach, and then the status. So there are a couple of statuses within our enrollment. There's active, there's relapse prevention, and then there is sort of resolved where we would take them off the list. We have relapse prevention plan date, their primary care provider, any APPs on the care team or advanced practice providers like a PA or nurse practitioner. And then if they're enrolled in other programs within UW Health, like RN collaborative care for, let's say, hypertension, diabetes, we have that in there as well. And so let's go ahead and click the next one. All right, I think my slide and your slide is a little out of sync here, but more columns. One of the nice things we have in here, and I think we might have to go back, is if you could go back one, sorry about that. So we have all the screeners too, like the scores. So one of the nice things we've done is we've seen the first GAD7 PHQ listed here. And then that is the one that we have performed right as we activate the episode. And then as we go, we take additional readings for the GAD7 PHQ9. And in columns, we have the change. So we have that PHQ change and GAD change. So we can see what the trend is throughout the care. So if it's going down, going up, obviously we'd like to see it going down. We'd like to see a negative number there. And if we're not seeing that, then maybe we do a team psych review. We also have whether they're being treated for anxiety or depression. And then we have our outreach for the primary care behavioral hate. I can't even talk today. Behavioral health collaborative care. You can see that in there. All right. So let's go to the next slide here. We have our bill date. I think I reviewed this, so we can go to the next one. Sorry about that. All right. I think we can go to the next slide then. So this is the part where we track time for charging the patient based on time using CoCM codes. And so this is back in the navigator. If you remember looking at that, we can put the time spent with the patient in, and then also the time spent performing chart review. And then this actually totals for this month and the previous month, so we can kind of see that data. but we also use some build that automatically drops charges based on this and sort of accrues till the end of the month, and then adds those charges to the patient, so we don't have to do the billing manually. We can go to the next slide.
Yeah. And then for our team psychiatry review, we have a tool called the plan and intervention, which essentially allows us to track all the times that our team psychiatrists are also reviewing. So you can see in there the date of the review is put in, any changes that were made. If you click yes on that psychiatric medications question, it'll have a little drop down so you can add like what kinds of meds were added or suggested. And then at the bottom there, it also has if we are entering into relapse prevention with a patient, we can track that as well and track the number of sessions that we're having. And right under that too is a little drop down when we push the relapse prevention plan that has a space to put in the actual plan, and that then can be blown into the notes. So we can print it off or send it via MyChart with that patient so they can actually see their relapse prevention plan and take it with them. And that is also part of our reporting workbench. We can see if a patient is in relapse prevention. Did you want to keep questions till the very end, Diane?
No, I think I think we should stop here just in case people there's a lot to, digest.
There is,
So
yes.
I think, yeah, so let's just stop here and see if folks have questions. You can either put something in the chat. I think you can unmute yourself and just present your question to Shanda or Tristan, but want to give people an opportunity to talk with the folks who've built their registry into Epic.
Good morning. This is Taj Baloo from Houston, Texas. And I have a question around what happens if the doctor makes a referral, processes the order, but the behavioral health clinician is unable to connect with that patient, or when they speak with the patient refuses.
Yep.
Is that information captured in the registry?
Yeah, can we go back a couple slides? I can show you where that is. Keep going. Yep. Yep. One more. Hold. There we go. Oh, there we go. So on this smart form, you can see anytime we get any kind of referral, we open an episode of care. So that might mean like we are still reaching out to that patient during the episode of care and we might never get a hold of them, right? And if we don't, or if we do get a hold of them, and in the situation that you just mentioned, Taj, like if someone is not interested, you can see at the bottom there, it says right before we resolve the episode of care, why? And you can see unengaged is one reason, they declined, barriers. So we have a whole list of reasons there at the bottom of our smart form that when we're closing an episode, that we mark in there why the patient is no longer with us. If it's either they completed their care, they couldn't due to insurance, whatever it might be, we mark that. Great question.
Yeah, that was good. How about other questions?
Hey, this is Stacy from Maine Health. In terms of the registry, the review, the consulting psychiatrist reviewing, the case with the BHCM, does the consulting psychiatrist put in a note which feeds into this report to tell us whether the case has been reviewed lately and what changes have occurred? Is there an actual template for that built?
Yes. So we have in Epic, if anyone's familiar, you have dot phrases that you can use. And our team psychs do have a template that utilizes a dot phrase so that we can basically pull a report that sees anytime anyone uses that dot phrase. We do need to kind of have that plan and intervention filled out for it to pull into the reporting workbench. But if we're looking overall, like how many on average team psych consults does a patient have? We can pull that report then and see how many times did X patient, each patient have that dot phrase in their chart. Does that make sense?
Yes, thank
Okay.
you.
And we got a question in the chat. What do you count toward chart review?
I mean, any kind of significant time, not just glancing, but like time actually digging in and looking at the chart. If we're talking about the team psych, or I guess I might want to clarifying question is, are we talking about like team psych when they're doing the review or just the care manager? Care manager, got it. Okay. Yeah. So for my care managers, I typically tell them like if you're doing more than just glancing at their last message or their last note, then we count it as a chart review. I will say, as the manager for the care managers, I try to not get people too hung up on like every single minute that they spend and just try to be as holistic as possible. So if they're doing more than just glancing at the chart, if they have to do some digging to find out either, what this patient's history is or why they were being referred or, what their history of depression is, then we try to generally add some minutes on, a couple minutes on, or whatever it might be for that chart review. Does that make sense? Yes. Okay. Sorry, I work with children, so I reflexively ask, does that make sense a lot?
That's awesome. Any other questions before we move on?
We have
Great
another
question.
one.
You want me to read it, Gina?
Dr. Wall, I think you already read the question. Does the
Yeah.
consultant document their notes in the EHR or in the registry?
Yeah, in the EHR. We make sure that any documentation regarding the patient occurs in the EHR so that it's searchable by other providers. Reporting workbench, you have to run to see it. So any documentation happens in the patient's chart.
Okay, any other questions before we move on? Okay, great. So now what we're going to do is talk about the AIMS Caseload Tracker, which is a web-based collaborative care registry that was developed here at the University of Washington and has been available and used to support collaborative care programs for the past more than 20 years. So it has been continuously improved over those 20 years and is something that supports many organizations nationwide. And I'm going to invite my colleague Susie Hunter to talk more about that.
Thanks, Diane. Hi, everyone. So as Diane mentioned, the AIMS Caseload Tracker is a HIPAA compliant and a web-based registry that the University of Washington offers to healthcare organizations across the country. We've been building collaborative care registries since 2004, and we've really carefully designed the software to support best practices using the latest research around effective behavioral healthcare. I'll mention that we do have two versions of the AIMS Caseload Tracker. One is a standalone registry that is used separately from your electronic health record. We also have a version that has data integration with your EHR. So we're pulling data from the EHR to display in the registry interface. So as we go through our little brief demo today, I'll be showing you what the registry looks like, what the basic version, the standalone version looks like. So next slide. I do want to mention, thanks. I do want to mention that the collaborative care team structure that Diane was describing earlier, here's a diagram of that structure. And I'd just like to mention that when you're using a standalone registry that's separate from your EHR, it's the behavioral health care manager and the psychiatric consultant that would be the primary day-to-day users of the registries. The PCP would continue to just work solely in the EHR and wouldn't typically log in to a system like the AIMS Caseload Tracker. So next, I'm going to show a series of screenshots of the AIMS Caseload Tracker and just show you kind of what it looks and feels like and some of the functionality that it has. Next slide. Here we're showing our caseload list. So this is analogous to the registry view and reporting workbench that we just saw. Here is the caseload list page. We're displaying one row for each patient on the caseload, and the behavioral health care manager curates this list so that it just includes all of the patients that are currently on their caseload. And I can give a brief overview of what we're looking at on this report. On the left side, we do have a flagging feature where the BHCM can identify patients in various ways. By clicking on the flag to toggle it on and off, they can identify patients that they would like to discuss during their next systematic caseload review with the psychiatric consultant. We also have a red flag to indicate when patient safety issues would be a consideration for the care team. And the idea is that the flag should be used within the context of the clinic's overall safety protocols. And we also have added a blue flag that we can custom label. So since we're in a little bit of a different situation, we're building a registry tool that needs to be general enough to fit the needs of behavioral health programs in various states and settings. So we've added some elements that allow healthcare organizations to configure the tool to meet their needs. Next, we have a status column. So similar to what we saw previously, we're showing here whether each patient is in active treatment, if they're in a relapse prevention plan status, or if they've been deactivated off the registry. And then next, we're showing different symptom scale scores. So right now in this version of the registry, we have the PHQ-9, the GAD-7, and also the PCL-5 to help track PTSD symptoms. For each of the outcome measurement tools that the organization is using, we're showing the first and most recent score from the current episode of care. So that would be the baseline score would be the score collected just before or during enrollment into the collaborative care program. The most recent scores are color-coded to indicate symptom severity using published cut points for each of those scales. And then you can hover your mouse over the score to see the date that it was collected. We're also showing an asterisk next to any score that's more than 30 days old to indicate that the scale needs to be re-administered. The next group of columns is showing information about dates of behavioral health contacts. So the first column is showing the date of the initial assessment. That's the first BHCM contact. We're then showing the date of the most recent follow-up contact and the date of the most recent psychiatric case review, and also the date of any relapse prevention plan if the patient has one. The next two columns are showing the total number of behavioral health contacts each patient has had so far in their current episode of care, and the number of weeks in treatment. So the idea is looking at those two numbers together, you can get a sense of the treatment intensity that the patient has had in their current episode. And then lastly, for organizations that are tracking minutes for billing, we are totaling up the minutes of service per month that have been recorded for each patient. And I should also mention that this report is interactive, so you can sort the list to bring patients with the highest scores to the top, or to bring patients who haven't been seen recently to the top, which can be really useful when you have a large caseload. And there's also a way to run this report for other providers at your clinic, which can help team members cover for each other during vacations or leave.
And Susie, I'll just add that the dates that are shown here for all of the contacts, those are also interactive. So if you click on that date, it's going to open up the note for that date so that you can easily from this view also toggle back and forth to the, to the more detailed data if that's what you want.
Exactly. Thanks, Diane. All right. The next report that we're showing is the reminders page. This is actually the first page that a BHCM would see every time they log in to the registry. And it makes it really easy to find patients that are due for an appointment, which is a key element of caring for an entire population, not just whoever walks into the clinic that day or is requesting treatment. So BHCMs would use this report to kind of prioritize their outreach efforts, making sure that patients are monitored regularly and stay engaged in treatment. And we have some logic tied to the frequency of these reminders. So the BHCM will receive reminders to check in with patients every 2 weeks. When patient symptoms are improving and they're put on a relapse prevention plan, then the reminder frequency drops to every 4 weeks. And then on the right-hand side of this report, we're also showing the date of the last unsuccessful contact attempt to help you decide when it's appropriate to reach out again.
So
And
we
did I-
have, oh, so go ahead, Susie. I was just gonna say, we have a question from Stacy, I think maybe about the prior screen. And her question is that feature for when you integrated this caseload tracker into your EMR? Stacy, you might need to unmute yourself to just let us know which feature you're talking about.
Diane, you mentioned that if you click on the date, it brings you to the note, but I assume that's only if this is integrated into your EMR, not as a standalone outside of.
Yeah, I can answer that. So if you're using the basic version of the AIMS caseload tracker, clicking the date opens the details that we've captured about what happened on that date, which I actually have a screenshot of later, and I'll show you what that looks like. If you're using the EHR integrated version, it does not click you back into your EHR. So we don't have that type of integration that allows us to flip back and forth between the two systems.
Okay, thank you.
Yeah. All right. Unless there's other questions, we can move on to the reports and statistics slide. I wanted to show another report that we have called Caseload Statistics. This is a really powerful report that shows how certain providers or clinics are doing across your program in terms of both service delivery, but also patient outcomes. And we've designed it to help you identify areas of improvement for your program, to promote use of symptom monitoring tools, to promote healthy caseload turnover, to extend the reach of your program, and also to identify patients that are not improving as expected and might need a psychiatric case review. So looking across all of the patients that are currently enrolled in your program, here providers can really easily see things like caseload size. We can see the caseload size, the current caseload size for each behavioral health care manager, average number of behavioral health contacts, the average duration of each visit. So we're looking at things like session lengths to promote best practice and shorter visit times. Use of scales for symptom monitoring, so we can see how often those scales are being completed. Effective use of the psychiatric consultant's case review time. And we're looking at things like average symptom scores, average remission and response rates. And you can run this report by care manager, but you can also run it by psychiatric consultant, by primary care provider, or by clinic location. So you can slice and dice the numbers in different ways, and they're all updating in real time as data is entered into the registry. Next slide. Here I'm showing what you see when you click into a patient's individual record in the registry. We've really summarized all of the details from their current episode of care. So at the top of the page, we can see a list of all of the behavioral health contacts the patient has had so far, along with any symptom scores that were collected at each visit. And then at the bottom of the page, we are graphing the scale scores over time to help visualize the progress that the patient has made so far. And then the next slide, I am showing how the information gets entered into in the first place. So this addresses Stacy's question a little bit more. Let's see. For our basic version of the registry, we are very aware that we want to minimize the need for duplicate documentation. And so we've designed this registry to collect just the minimum amount of information that we need to compile those caseload management reports that we just saw. So at each contact, the BHCM would enter the date that the contact occurred and any scale scores that were collected. And that's it. So the idea is that it's a very brief documentation need in the registry. The BHCM would record the narrative portion of the note as well as the symptom scores into their EHR. That remains the legal medical record for the patient. It's accessible to the entire care team. So only the date and scores are recorded in the AIMS caseload tracker that we're looking at right now. Next slide. I wanted to show a couple more reports that we have available. We recently added the collaborative care quality metrics. This is a set of measures that give you some visibility into key process and performance data. This is a little bit different than the reports that we've looked at so far, because here the metrics are calculated for each month. So we're looking back in time to see performance in each month time period. By looking at metrics over time like that, it helps you assess trends in your program. So you can see change in performance over time, and you can identify areas for improvement or areas where successes should be recognized, where things are working well. So the measures are listed here. I think there's 7. The caseload reach measure is looking at the proportion of new patients that are enrolled each month. This is to reinforce the concept of healthy caseload turnover and appropriate completion of active care management as patients achieve their treatment goals, to ensure that your program is able to reach more patients and patients are able to receive care when they need it. The engagement measure is looking at the proportion of patients that have at least one behavioral health contact each month. We know that early and frequent contacts are associated with better outcomes. So this seemed like a very important measure that we should be exposing to or making visible to the team. Measures completion is evaluating the consistent use of evidence-based symptom measurement tools, as Diane was reviewing earlier. This is a foundational task for measurement-based treatment to target, and it's an important thing to keep track of. Next, we have some outcome measures. There's a set of 3 for depression, anxiety, and PTSD. This is looking at all of the patients that have been in active treatment during the month for some minimum amount of time, how many of them have achieved a 50% improvement on their PHQ-9 score, a 5-point improvement on their GAD-7 score, or an improvement on their PCL-5 score. And I don't have that number off the top of my head. We did base it on the published cutoffs for the PCL-5. And then the last measure is looking at psychiatric case review. So out of all of the patients that did not meet the previous 3 outcomes measures, out of those patients, how many at least had a psychiatric case review completed during the reporting month? Thank you, Diane. The last report that I wanted to show is about time tracking. So if your organization is tracking minutes in the registry, we have this report available that shows the number of minutes of service for each patient. And we're showing the current month and the past 12 months. And the idea is that it can be used as a reference when billing for CPT or CoCM codes, or to demonstrate for audit purposes what services were provided. Next slide. I wanted to just talk briefly about what it's like for healthcare organizations who choose to use the AIMS caseload tracker. We find that it's a fairly simple tool. It typically takes about less than an hour for each person to learn how to use the registry and practice using it. Organizations that wish to use the AIMS caseload tracker must enter into a software license agreement with the University of Washington. That includes a data storage agreement and a business associates agreement. And we do have instructions on how to license and more information on our website, which is listed on the slide. And I believe that is all I have. So I will open it up for questions and discussion. Thank you all so much.
So yeah, any questions from anyone? And this could be about what Susie has just talked about regarding the Ames caseload tracker. Any other questions for Shanda regarding their build into Epic, or any questions about measurement-based treatment to target as one of the key principles sort of underlying the effectiveness of collaborative care?
I have a question that may or may not fit. When do you begin the relapse prevention plan?
So maybe I can take that one, or Shanda, I actually also could as well, from, so what their practices are. What we recommend when we're working with healthcare organizations is that you really look at that relapse prevention plan and kind of start that process kind of fairly early on. What we've seen is that if you wait until the patient is completely better, a lot of times they'll be like, okay, I'm better. And then they just don't come back, and you never have the opportunity to do that relapse prevention plan with them. And it really is such an important, there's published literature out there about the importance and the utility of relapse prevention plans as part of collaborative care. So, I often feel like it's one of the things that people kind of drive by, like sort of like, oh yeah, they focus on the other items. They don't really focus on relapse prevention planning, but it really is quite important. And so you really want that patient to have the plan, before they end care. And like I said, sometimes they start feeling better and they may just drop out. So we really recommend that you start that plan early on. You introduce the concept of the plan. You start with, it includes things like warning signs. What are the personal warning signs for that particular patient? Like, what were the symptoms that brought them into care? They're different patient by patient. There's a whole list of symptoms that are common, but usually patients have their own set of symptoms that they were having. And so that's one section of a good relapse prevention plan is, what are your personal warning signs? And it's easier to document that early on when those are, those are sort of fresh in their mind, right? So, these are things that are happening right now or very recently. And so getting those down and remembering, once the patient starts feeling better, it may be harder to remember what it was like, when they were really not doing well. And so kind of getting that process started and then working on that plan over time with the patient. And so then if they do, just kind of suddenly drop out of care because they've gotten better and they just don't feel, like they need to come back, you've got that plan that you've been working on over time, and you can send that to the patient, through the patient portal. You could mail it to them, but it's something that you've really built over time and you would have done by the time that it's really time for them to sort of end their episode of care. I don't know, Shanda, how do you guys handle that?
I totally agree, Diane. I often tell my care managers that the relapse prevention sneaks up on you. So you might be like 10 minutes into a session or like on a phone call with someone and realize, oh, we're in relapse prevention because they're doing better. They seem like they've been able to sustain it. And that's the moment when you have to start talking about it, is the moment that you, as the care manager, realize, oh, this person is better, is immediately start addressing it.
Thank you.
We've got a question in the chat from Taj. Where did you get the quality metrics you highlighted? Did you create these, or are these industry-wide accepted measures?
And do you want me to take that one?
Yeah, go ahead.
I'm happy
Susie.
to. Yeah, so it's a combination. So we did create those. We have an internal registry work group that's comprised of all of the collaborative care experts and researchers that we have at the AIM Center. We based the measures on recent publications that showed the key components of effective collaborative care for quality of care and good patient outcomes. So it's all based on the published literature. The outcomes measurements, especially the depression response measure, is based around the HEDIS measure for depression response, where we're giving patients a certain window of time to be in treatment, and then we start looking for that 50% improvement on PHQ-9. So we did align the measures around national measures when possible, but the selection of the key components that we're looking at is something that we came up with at the AIM Center that we felt like we could stand behind when offering this registry to healthcare organizations. Diane was actually part of that group that designed the metrics. Do you have anything to add, Diane?
You covered it really nicely. Yeah, we really tried to look at, what is out there in the published literature. I think that's one of the real strengths of collaborative care, is that there is such a robust published literature around the key components of it, and the things that really drive patients getting better, like that slide that we looked at early on regarding measurement-based treatment to target. And so we really used what's out there in the published literature to help drive the development of those quality metrics. Other questions?
This isn't specific to the registry, and you can steer me in a different direction if it's not the right time, but how do organizations start this where they're if they're in a state where their Medicaid has not turned on the codes yet? Is there any way to begin this service if your state insurance doesn't cover it?
Well, I'll say that, we work with healthcare organizations all across the country, and not all of them are located in states that have turned on the collaborative care codes for Medicaid. There are other ways to finance collaborative care. The collaborative care codes are particularly nice because they cover all the elements of doing the collaborative care. It's not just the time that you spend doing brief behavioral interventions. You can also count the time, as Shanda was showing, the time doing, chart reviews. In our registry, you can also, you count the time in the systematic caseload review with the psychiatric consultant. You can count the time consulting with the primary care provider and doing care team coordination, and there are all of the things that go into collaborative care. You can count up all of those minutes toward the billing code for that month, and that's one of the things I think that's particularly attractive about the collaborative care codes. However, it's not the only. There are plenty of really strong collaborative care programs out there that don't use the collaborative care codes. They use the kind of the more traditional psychotherapy codes and just bill for the time that they spend doing those brief behavioral interventions with patients. And then also, use other codes for example, the interprofessional communication between the psychiatric consultant and the primary care provider. There are codes for doing screening, so you can cobble together other codes and use those instead of the collaborative care codes if you are in a state that hasn't turned on the collaborative care codes for Medicaid, and you've got a large Medicaid population. It's less of an issue for healthcare organizations that don't have a significant Medicaid patient population. Or, if you do, then there are other strategies that can work.
I will also note that we started billing collaborative care codes before we had Medicaid's support. They were not going to accept these yet. And what we did is we actually requested that since Medicaid wasn't covering them, that they essentially write a response saying they wanted us to continue using the psychiatric CPT codes or the therapeutic therapy CPT codes, so that we were specifically billing Medicaid differently for a short period of time because that's what they had requested. So we worked with our state Medicaid board to essentially have them request that they continue paying us the way that they had been until they were able to change the law.
That's an interesting approach, Shanda. That's a way to get around, you're treating everybody fairly.
Yep.
And for the request of Medicaid, that's brilliant.
Yeah, it worked. And then a year later, they accepted the code. So
Thank you.
There's another question in the chat. Veronica is asking, are LCSW able to build the collaborative care codes, or they would use the social worker codes?
So regardless of who is in that behavioral health care manager role, because that role really can be filled by a variety of different types of professionals, and that can be an LCSW, it can be a registered nurse, it can be a licensed professional counselor, it can be lots of different folks in that role. And it doesn't matter if you're billing the collaborative care codes, those codes are billed incident to the treating medical provider. So the bill actually goes out under the NPI number of the medical provider or the primary care provider. So it really doesn't matter what the licensure or the training or educational attainment is of the person that's in that behavioral health care manager role. It can be anyone, in any of those roles. And frankly, I'll say for Medicare, this is not true for a lot of commercial insurance plans, and it's true for some, but not all state Medicaid plans. It doesn't even have to be a licensed provider according to Medicare. It just needs to be someone who has some specialty training in behavioral health, and that could include someone at a bachelor's level. But again, you really want to look at your payer mix and understand, what the requirements are of your commercial payers and of your state Medicaid plan, before sort of embarking on folks at that level. But it is billed incident to the treating medical provider. And so the collaborative care codes, that's how those function. Looks like we have, oh, good, Shanda, there you go. Yeah. Any other questions? These are good questions.
Sometimes it takes a minute for our participants to warm up and unmute and ask questions, but folks, please feel free to unmute or type in your question in the chat. We have experts here, so and it's a very safe place for you to ask any questions. So please feel free to do so. Okay, I think we are good for this session. Well, thank you, Diane, and everybody, Dr. Wells and Susie, for your time and for this amazing presentation today. I appreciate you coming in and doing this session for us. I'm going to pass it over to Victoria if you want to talk briefly about the process of evaluation.
Yeah, thank you. So as always, I will be sending out a follow-up email after this, and it'll have the link to our evaluation survey. And so in you filling out that survey, that's how you're going to receive your certificate of attendance, which can count towards your CEUs. And I'll also send the presentation in that email. So just please look out for that link and make sure you submit the survey. But that's all. Thank you all so much for today.
All right. Well, thank